Hey, everybody. Welcome to our webinar today presented by Integration Health, the heart of ECLS care. We are very excited to have the preeminent ECMO reimbursement expert and our strategic partner, Dr. Ara Balkian, here with us today. I did want to let everyone know that we do have our Q&A turned on. And so if you have questions, feel free to submit those there during the webinar process. Some moderators will be reviewing those, and then we'll try to pass those over to Dr. Balkian. He may get to them during the presentation or maybe more towards the end. So we'll just kind of go with it and see. Thanks for joining us. Dr. Balkian, I'll turn it over to you.
Thanks, Neil. Hi, everybody. Thank you for joining. I think this really important discussion around ECMO. We all know how important ECMO is to our patients and to our communities from a clinical perspective, but we also know the challenges that the C-suite and others may pose to us around what is the financial sustainability of this program. It's an expensive program. You have to invest quite a bit to make it work. And I'm hopefully here to help show you that we should all be able to prove the financial success of our programs. And if it's currently not in that way, what can we do to optimize it? So really, we're going to give a brief background on myself and Integration Health. You can't really understand how to build a financially successful ECMO program without first understanding how do hospitals get reimbursed. So we'll have a bit of a primer, and after this, you will be um, I wouldn't say an expert, but you'll probably know more than 95% of people in your hospital around exactly how the hospital gets reimbursed and what we could do to optimize that. We'll get into the details of ECMO reimbursement. What are the charges? What's the revenue? And then just provide an overview of the ECMO revenue cycle so you have understanding of all the nuanced features that we have to get right to make sure ECMO is financially successful. And as Neil mentioned, I might pause at times to see if there's a questions along the way. Obviously, it's easier if you type in those questions related to a slide. And Neil, feel free to interrupt me if there are questions that you can ask for a particular topic, and we'll do it that way. And then we'll leave time at the end for questions as well. So, as Neil mentioned, at a high level, I've been with Integration Health for about 3.5 years now. I think they're an excellent company in terms of the services you see here. Really, one of the things that we're talking about here that directly impacts is the ECMO program development. Once again, which gets not just to the clinical and operational elements of how you're going to provide ECMO to your patients, but then how do you administratively and financially track this and make sure it's a successful program? So not only is it not cut out in future budget cycles, but actually expanded. So as mentioned, I'm a senior strategic advisor with Integration Health. Really, my goal is to work with hospitals directly to help them set up their program financially in a way that's going to be successful, in a way that they can track it. And we've done this at a number of hospitals throughout the country. I've been at Children's Hospital Los Angeles for about 28 years as the chief medical director in a practicing pediatric hospitals. And in that role there, I do quite a bit of work with revenue cycle and other areas of finance to make sure our programs are properly set up and we're financially doing what we need to do. And then the third element of how I know the space is I founded a consulting company that's focused on pediatrics, but we do a lot of revenue cycle work and similar to what we're talking about here, particularly in the pediatric space where we're under reimbursed, particularly compared to adults. This is something important and something I've focused on over my career. So when a patient gets admitted to the hospital, two bills are generally always created. There are some nuances for bundled fees where it's one, but for almost all of our patients, two bills are created. There's a professional fee, which is when the individual clinicians, usually physicians, but you can have advanced practice providers billing professionally as well in certain states. We see the patient, we document, and then we bill for that service. And it's one bill for each day, supported by our documentation. Okay. That's generally small dollars compared to what we're mainly going to talk about today is the hospital side, sometimes referred to as the facility fee. This is where you see on the news a patient goes to the ER, is seen for 10 minutes, gets a Band-Aid, and they get a $10,000 bill. And they're like, what's going on here? This is nuts. I was there for 5 minutes. I just got this Band-Aid. Well, the hospital has to pay for that ER to be open 24/7, to be staffed, to have the machinery, and so on and so forth. And it's that hospital or facility fee or facility bill. It's really the big dollars associated with healthcare costs. It's hospital billing that covers for the entire hospitalization, and it's one bill submitted after discharge. Okay. There are some provisions for interim billing for long length of stay. For the most part, it's one bill after discharge. So briefly on professional billing, because the rest of the talk, we're going to talk about facility billing. We have some cheat sheets to help guide your clinicians on how to properly bill for professional billing for ECMO, right? There's some nuances around if an ICU doc who's managing the daily ICU care, they may be managing the daily ECMO care. Can they bill for both? You initiated ECMO today and you cannulated the patient. Can you bill for both? So there's some general guidelines around that we could help with. There are a dozen other examples that are a little trickier that we always say we defer to your compliance and professional billing team to work through those. But on the professional billing side, it's even though it's lower dollars compared to facility, it's still important to make sure we do it right. And so there's some support around that for you. The most important element of how successful your ECMO program may be is far and away what is the payer mix of your hospital, and more importantly, the payer mix of the patients who happen to get ECMO. Payer mix is basically just what's the payer type or class, Medicare, Medicare Advantage, commercial. You see the rest of it down here. And there are others, right? You can have TRICARE, Champus. So that is paid for your patients. So this is the most important element, particularly for things like ECMO, where you might be just be doing 10 runs, 20 runs, 30 runs a year. If you happen to have one year where the majority of your patients happen to have commercial insurance that needed ECMO, you're going to show a very successful program. And the next year, you may have by just happenstance, Medicaid patients that were the more majority of the patients that needed ECMO, and that's a very lower paying payer, then your program financially is not going to show what you were hoping for it to show. So I want to lead with that because one, it's mainly out of our control in terms of what our payer mix for the hospital is. And in particular, which patients happen to need ECMO for that given year. So this is really important. You can divide payer mix by the percent of discharges for the year that were paid by Medicare versus commercial. Some places say, what are the net revenue for the year? What percentage of that net revenue came from Medicare versus commercial versus Medicaid? So when you pull that, make sure you pull it and you are comparing apples to apples. For me, the most helpful part is pulling it by discharges. So I'll start with that. You can make a perfect pro forma and model it out and look like you have a very profitable program. And if your payer mix wasn't favorable that year, it's not going to look so great. Next is really what are the payer payment models of these major payers, right? I'm not going to focus too much on bundled payments, case rates, and capitation. Those are generally less common. The big ones are percentage charges, and it's exactly as it sounds. The payer will pay you 40% of charges, 50%, 30%, whatever your contract states. Per diem is just Latin for per day. So you get a contractual amount per day, 8,000, 5,000, 10,000, whatever your contract states. Those are two relatively common payment models within Medicaid programs and commercial contracts. The most common payment model in the country for adults and peds is something called the DRG model, the diagnosis related group. It'd be easier if they just called it groups of related diagnoses because that's really what they are. And it's one payment for the entire stay. And Medicare pays by the MSDRG model, which stands for Medicare Severity. Commercial payers oftentimes have contracts that are MSDRG or APRDRG, and most state Medicaid programs pay for that model. The tricky part with Medicaid is it's really state dependent. So all of you have some element of Medicaid patients, some very high, particularly if you're a children's hospital. About 55% of all discharges from children's hospitals are paid by Medicaid, which is not a great payer at all. And so you can look here on this model and see, probably went straight to your state, which one of your state pays by the APRDRG model, or all patient refined diagnosis related group, versus the MSDRG model, which is Medicare severity diagnosis related group, which is how Medicare pays. And you see a mix of others there. And even within one state, even within the same states that are APRDRG, the payment models can be very different. Okay. So we know that the majority of your patients are going to be paid by the DRG model, likely MSDRG. How is the DRG determined? Patient gets admitted, your clinicians document their notes, you have hospital coders that enter all the variables in the blue boxes up top into a computer program. Solventum or 3M is about in 90% of hospitals. And this coding software computer program automatically generates an MSDRG or Medicare Severity Diagnosis Related Group with up to 3 severity levels, or it creates an APRDRG with up to 4 severity levels. You can see there's only about 340 or so, and it can vary by state of these. So all of our diagnoses automatically get placed into one of these MS or APRDRGs with their associated severity levels. Okay. Once an MS or an APRDRG severity level is automatically assigned by the computer program by the elements entered up top there, a relative weight is assigned to it. You can see this snippet here is just the outcome of that computer program I was talking about earlier. All those variables were entered. It spit out a DRG 138, which I could just tell you is bronchiolitis. It's a very common pediatric admission. S is a severity of 3. Remember, the 4 is the highest. R is a risk of mortality of 2. It has a relative weight of 0.7. So the relative weight is just a scale or a ranking of the resource intensity of that type of patient. The higher the relative weight, the higher the acuity of the patient from a scoring perspective, the higher the payment to the hospital. This has nothing to do with professional billing. This is just facility billing. So if we look at MSDRG relative weights, this is how Medicare pays, right? This is all CMS for the entire country. It's the same for the entire country. That's what's different about Medicare versus Medicaid, which is state by state. And this is for fiscal year 2026, which is October 1st through September 30th. So this will change. October 1st is this year. You can see what these relative weights are like. ECMO has one DRG. It's called DRG 003. And it's not just ECMO, it's ECMO or patients with a tracheostomy with mechanical ventilation greater than 96 hours. You read the rest of it there. So if you're a hospital that is thinking about ECMO, but you don't have ECMO patients yet, you likely have DRG 003 patients. I would pull that data and see what you're getting paid for them now. This ECMO DRG is assigned a relative weight of 21 by CMS. That means that this type of patient is 21 times the average resource intensity of a patient. That's how you can kind of look at relative weight. Okay. And you can see that also that there's GMLOS or geometric mean length of stay associated with ECMO. That'll be important later. I'll show you. And then the average length of stay. So the GMLOS is just kind of like median. It's a statistical way to minimize outliers, and it's important for transfer patients. We'll talk about later in terms of determining payment. Or you can look at, so ECMO has 1 severity level, as you can see there. Sepsis has 2 severity levels, with major complication comorbidity, without major complication comorbidity. And you can see the relative weights are significantly lower for sepsis than it is for ECMO. So you can have a septic patient who needs ECMO support, and their DRG changes and the relative weight changes, which ultimately will increase payment significantly. And then lastly, COPD has 3 severity levels. So just once again, as you're learning hospital reimbursement, this is how the MSDRG model works. Some have 1 severity, some have 2, some have 3. And the most important element of all this is what is the relative weight associated with it. When you look at Medicare and the top 10 highest paying services or DRGs within Medicare, ECMO is the fourth highest paying service. So that's why when you're in a hospital and folks are telling you, we're not going to make money on ECMO, it's a really expensive case. It really shouldn't be the case if structured properly because it is top 5 paying service, as you can see here. And you can see the other elements up there. If a patient receives ECMO care, they will always fall into DRG 003, except in 2 scenarios. They received any type of transplant, solid organ or bone marrow or CAR T cell there, and you can see that it'll go into that DRG. The second time is if they received a certain type of ventricular assist device, like a certain type of Impella device. Not all Impellas, but certain types. And then it'll fall into DRG 001, as you can see, is higher paying. So ECMO will always be one of your top paying DRGs. If not, if they got a transplant or they got the certain Impella, they're actually going to be even higher paying. Okay. We just showed you the Medicare's top 20, top 10. Every state's different. If you look at Texas's top 20 relative weights, everything shaded in blue is an ECMO DRG. So in APR DRGs, which is how mostly Medicaid pays, there are 2 types of ECMO DRGs compared to the 1 type in MS DRGs. There's neonate with ECMO with 4 severity levels, and then there's just ECMO with four severity levels. As you can see, this ECMO, which is if you're only providing adult care, your adult Medicaid patients would fall into DRG 9, this is severity level 4. And you can see in this Texas example, it is what is the sixth or seventh highest paying DRG. So in Medicare, it's one of the highest paying services. And in Medicaid, it's routinely one of the highest paying services in every state that we do this exact kind of analysis on. And the payment model in Medicaid is a little bit different or can be different than Medicare, but it's the same type of formula. So, and it varies by state. So in California, it's a base rate times the relative weight. You guys know what relative weight is. And then they can multiply it times other adjusters if you're under 21, as example. Florida has its own formula. They add additional payment if you're a trauma hospital. Minnesota has a very complicated formula where they add additional payments if you do research and have a high proportion of Medicaid. And Texas is a base rate times relative weight times chirp payments is just additional payments to get you closer to commercial rates. So that's how Medicaid pays. It's that relative weight we just talked about and how you know how that's now created, which is high for ECMO times a hospital specific base rate, and it gets you to your payment. It's one payment for the whole state. When we go to Medicare, similar concept, much easier formula. It's just base rate times relative weight equals total payment. And so base rate is hospital specific. We'll get into that. Relative weight we just talked about, right? That's a ranking. And we all know what the ECMO relative weight is in MSDRGs is 21. And any of you can go to CMS Web Pricer, just Google it, and you can see what you're seeing here and enter your hospital's provider number, which you can just easily Google, enter admit and discharge dates, assume some charges, make sure your covered days cover their length of stay, and then put DRG 003, which is ECMO, and it'll show you exactly what Medicare will pay your hospital for ECMO care or whatever DRG you want to plug in there. And it also has in the same site what your operating cost to charge ratio is. In this example, it's 23%. We'll talk more about why that's important later. So if we take one specific hospital, once again, these are real. This is real data from hospitals that we work with, though you won't know which one it is. And we take their total charges per case. This is data they gave us of 750,000. We plug it into that calculator. It shows us that this hospital is going to get 180,000 for this ECMO patient if that's how much they charged. Okay. And remember, payment is hospital base rate, which is specific to your hospital based on the elements in this blue box here. So if you're in a higher cost city or state, you're going to get higher payment. If you have a higher amount of uncompensated care, if you have a training program, if you have penalties or bonuses for value-based purchasing, readmissions, and so on and so forth, your hospital base rate varies by your specific hospital and can change every year. You multiply that times the relative weight, which you all know what that is. It's 21.22 for ECMO. And you get the total payment, which I just described, which is 180,000. But you see this element here of outlier payment, really important for ECMO care. What's an outlier payment? Outlier, or the commercial payers usually call it stop loss, is just the mechanism to protect our hospitals from really significant losses for a very expensive case. And the way we determine, or payers determine, we qualify for outliers, just they have a threshold to see if you lost a certain amount. So for Medicare, if you lost 40,397 in this year, this will change October 1st. Medicare will pay you 80% of all losses beyond that loss back. So how do you determine what your loss is? You take your charges for that case, you multiply it times your hospital specific cost to charge ratio, or CCR, and that tells you what your cost is. So if this case had $1 million in charges and this hospital has a cost to charge ratio of 16.3%, you multiply 16.3% times $1 million. The cost to the hospital for this case was 160,000. That's kind of how you determine it. And then if you take the DRG payment, which was 108,000 in this example, and you subtract it from the cost of care, which was 160 grand in this example, and you lose over 40,000, that's when outlier kicks in. Okay, so that's really how it works. Cost to charge ratios vary significantly, not just by state. And you can look at this data from 2020 that shows the range of average cost to charge ratios is 15% to 79%. What that means is for the hospital, that's 15%, or the state, If you have a charge of $100, the actual cost of that item was $15. So it just shows you what that is versus the hospital with the state with 79%. Their charge is more in line with the cost. It was 80% of that charge is the actual cost. But these are averages for the state. You could look, and it's all public information. You could look at some for-profit large hospital systems, and their cost to charge ratios are 5%, meaning that if they have something that's charges $100, the actual cost of that item was $5. So they have very high charges in relation to what the actual cost is. This is why cost to charge ratios are really all over the map and very difficult to say, hey, hospital X charges $1 million per 20-day ECMO stay. Why aren't we charging you $1 million? Well, you first got to look at what's their cost to charge ratio versus yours. If your cost to charge ratio is 15% and theirs is 30%, you're going to have to charge $2 million compared to their 1 million likely to get the same kind of reimbursement. So, what is the appropriate hospital charges that we just discussed? How do you create that, especially with the nuance of cost to charge ratios being different? First, you have to really kind of slightly understand how hospital costs are kind of defined. So, you guys aren't going to be CFOs after this, but if you care about how to properly set your program up, you have to have some understanding of these. So, there's direct costs. Let's take about ECMO. So these are directly attributable to patient care. So your ECMO specialist, your bedside nurse caring for that patient, that lab, you got the disposables related with that patient, and the direct patient care. So the ECMO coordinator, right, is somebody who's associated with patient care on the floor. Indirect costs are things like the hospital CEO, marketing, HR, right? These are important costs, but not associated directly with patient care. Variable are costs that change with the number of ECMO patients you have. So ECMO specialist cost could be if you have ECMO specialists on staff, maybe that's not variable. But if you use, Integration Health as an example, and you're paying per ECMO case on a per shift level, that's a variable cost. The disposables you use for your ECMO patient, that's a variable cost, right? You're not gonna incur those unless you have a patient who's using that. Fixed cost, it doesn't change with the volume of patients. So the ECMO coordinator is a perfect example. That's a direct cost because it's associated with patient care, or it can be, and it's fixed. Whether you had 20 ECMO patients that year or 10, you still have that cost of that ECMO coordinator. So it just gives you an idea a little bit about how to outline those as you create a budget or pro forma or forecast what your ECMO program might look like. And what's important is that your ECMO daily charge really needs to account for all the ECMO program costs, which can be significant. Training, precepting, bedside RNs are usually one-to-one, your ECMO specialists, your coordinators, right? You have equipment and service contracts. What we oftentimes find is hospitals don't properly account for all your ECMO costs as they create an ECMO charge. So if you don't know what your daily ECMO charge is at your hospital, send an email to your revenue cycle or finance folks and just say, hey, what is our daily ECMO charge on our charge master? You might have a different charge for first day of ECMO. You might have a different charge for subsequent days of ECMO, or it might be the same, but you really want to try to get a good sense of what that is. And the way you properly set it is once you know your yearly ECMO cost. Let's assume you have a hospital that does 20 runs per year. At each of those runs, you have 5 days of ECMO, right? This could be 7, it could be less. So we know we have 100 ECMO days a year. Okay. Let's assume that with all the costs I talked about in that first bullet point, it comes out to $1 million. $1 million divided by 100 ECMO days is $10,000 per ECMO day. So you might think, hey, if our daily ECMO charge is $10,000, we're good. It covers our costs. That's not the case because you haven't yet factored in your cost to charge ratio. So if you want to know if your daily ECMO charge is accurate, find out what it is. Find out what your cost to charge ratio is. You can literally Google it and find out. In this example, it's 16%. Multiply your daily ECMO charge with the cost to charge ratio and see if that makes sense. In this particular example, what is that? $1,600. So you know that it costs more than $1,600 a day for ECMO care if you have a $10,000 per ECMO day. So the payers apply this cost to charge ratio to all of your charges on your charge master, all of them. So if you don't properly adjust your daily ECMO charge to account for that, you're just automatically starting behind and undercutting what your reimbursement should be. So if we got to $10,000 per day, we then divide it by your cost to charge ratio, which is 16%. The proper daily ECMO charge for this example in this hospital is $63,000, which might seem a lot, and it is a lot, but we got there compliantly through math, and I welcome any audit to come in there and figure out how we did that. The problem is most hospitals don't do charges this way. They hire a consultant, comes in, looks at your charge master every year, every other year, compares it to peers in the community or whoever you want your peers to be, and says, oh, you got to adjust your charge master by 5%, 10%. But ECMO is a very expensive service. And if you don't charge for it properly, it's going to be very hard to fall into outlier status appropriately and get additional reimbursement. Okay, this is a really important point that I don't see any hospital doing correctly when we first work with them. And it's important to do that. This element, this concept of dividing your actual cost by your cost charge ratio applies to all your charges, not just ECMO. So your oxygenator, your disposables, on and on and on. All those have to be properly adjusted. Otherwise, the payer is just going to come in and just take out those charges, and you're not going to get paid what you're supposed to get paid. So let's assume we did that right, and now the charges actually are 1.5 million for this case. The hospital base rate times relative weight formula payment stays the same, but now you start to see a little bit of outlier because remember we have more charges, which leads to more cost. And you go to that outlier formula, looks like we lost over 40,000 in this case, and you start getting 80% of all the losses beyond 40,000 in Medicare back, which in this case is $30,000. Say we're at $2 million in charges, which is not uncommon at all for a 20-day stay at a hospital that has a 16% cost to charge ratio. Now you can have another hospital that has a 5% cost to charge ratio, and their charges might be $3 million for this exact same patient. They just have higher charges for exactly the same things you might be doing that lead to 2 million in charges. You could have another hospital that has a 40% cost to charge ratio. Their charges might be $1 million and yet incur the same cost. So that's why it's very hard to just compare charges from one hospital to the other. And in this example, you can see outlier payment went up even more, almost 100 grand, leading to overall payment of 280,000 for this case. Okay, so very important to set your charges correctly because outlier payment can be very important for high cost services like ECMO. And then when you look at patients that diagnoses that are amenable to ECMO, sepsis, respiratory failure, you all know what they are more than I do. And you look at what that Medicare reimbursement is using that same CMS web price or website compared to what Medicare will pay if they happen to go on ECMO. And all you need is like you can be on ECMO for an hour and you fall into an ECMO DRG. Okay, as long as if you're in heart lung bypass in the operating room, obviously that doesn't count. But if they couldn't get you off the machine and they take you to the ICU, and you're on ECMO, and so that actually counts. There's no time minimum that you have to be on ECMO for it to count. And you can see the difference in reimbursement or payment, whether they received ECMO or not for that same kind of diagnosis. Transfer patients, really important because lots of your patients may either be transferred into your ECMO site or may get transferred out to one of these bullet points on the bottom. So there's something called the PACT policy or post-acute care transfer policy that CMS has. Remember, there was 340 MSDRGs in CMS. This policy applies to about 280 of them. So this isn't just for ECMO. It applies to the vast majority of your patients, and ECMO being one of them. And the way it works is if the patient stayed the GMLOS or the geometric mean length of stay for this DRG, it doesn't matter if they got transferred, you're going to get the full payment. So if the length of stay is greater than 22.9 days, which is the GMLOS for ECMO, or if they stayed less than that, but they were discharged home, you're going to get the full payment. But let's just say they stayed less than 23 days and they went to one of these bullet points below, which they very well could have, right? These are sick patients. They maybe got transferred to another acute hospital closer to their home. They're off ECMO at your site, but they still need inpatient care, they get transferred, or they get transferred to rehab or a SNF, right? These are all realistic things that could happen to these very sick patients. Or they go home and they get new home health care within 3 days. So there's that bit of a nuance there. If they went to one of these six bullet points and stayed less than 22.9 days, you don't get the full DRG payment. You don't split the payment with the other hospital. Let's just say they go to the hospital. That's not how it works. Medicare just converts your payment to a per diem. So the way they do it is, let's just say this example above, what was it? Let's just say $200,000 in payment, right? So if you were going to get $200,000 payment by the DRG, if they would have stayed 23 days, but they only stayed 10, the way you do it is you take 200,000, you divide it by 23, which is the GMLOS, 22.9, gives you a per diem payment of $8,700. You do 8,700 times 10 days, you're going to get about $87,000 payment for this ECMO patient who stayed 10 days and then went to a SNF versus the $200,000 you would have received if they would have gone directly home or if they would have stayed 23 days. So as you're looking at your ECMO program, and you're looking at the reimbursement and you see one that's low and you're wondering why, we should have gotten 200 grand for this payment, make sure you have what the discharge disposition was in that column so you know whether they went home or whether they got transferred. And this is really important. There's entire businesses that track this for hospitals. Follow the patient. The patient has to stay one midnight at least at the SNF or rehab facility for it to count. If they go there, they hate it, and they go home, it doesn't count, and your discharge disposition should be home, and you should get the full payment. So this is just another nuance and wrinkle of ECMO reimbursement that you should track to make sure you're getting it right. So we have our payment. We just talked about that, right? Normally, it's usually going to be MSDRG or APRDRG or percent of charges or per diem. That is that revenue that comes in for this ECMO patient. Contribution margin is you take that revenue, you subtract out the variable costs. You guys all know what that is now. That's the cost associated with that patient being there. So that specialist, the bedside nurse caring for the patient, the labs you did, studies you did, the disposables, not the cost of your C-suite and marketing and HR, all those things, but just the cost associated with that patient. That's what the contribution margin is. It's a good way of tracking service lines like ECMO to see how they're doing and what's the financial health of that program. Okay. So we
Dr.
recommend you,
Balkian,
yeah.
I just wanted to hop in and had a couple questions before we get too far away from it. One is in a cannulate and ship model,
Yep.
if the patient is cannulated in the ED, do they have to be admitted to an inpatient status to capture the DRG?
The,
Uh,
the answer is yes, but if you ship them out one day anyway, you're not really going to get paid much, right? You're going to get whatever you would have been paid by DRG. Say it was 200,000 divided by 23. What was that? 8,700 per day. You kept them one day, you're going to get $8,700 for that patient.
okay. If you transfer a patient on ECMO, do you still get the per diem payment or does the discharging hospital get the reimbursement?
Both of you get, so if you cannulate them in the ER, then you transfer them, or you inpatient care and you transfer them.
This one just says if you transfer a patient on ECMO, it doesn't have more
Got it.
details.
Yeah. If you transfer them out of the ER,
It says
it is like
inpatient. She said
inpatient. Okay.
inpatient. Yeah.
So it depends on the length of stay. If they were in your hospital 23 days, you're going to get the full payment.
Okay.
Okay. If they were less than 23 days and you transfer them to another hospital, that's bullet point one up there, then it'll convert to that per diem payment, which I just talked about, and depends on the length of stay at your hospital. You
Okay.
don't you don't split it with the other hospital. The other hospital then, as soon as they arrive there, is their own time frame, is their own if they need ECMO again, right? So they'll get paid for that. It has nothing you don't split any reimbursement with the retransferring hospitals.
Okay. The next one is if the hospital staff and equipment are going to an outside hospital to initiate ECMO and then transporting the patient to one of our facilities, would it be appropriate to charge for the initial ECMO charge even if off-site, since it's our staff and equipment performing the procedure?
I mean, you won't be able to charge the daily ECMO room and board charge because that's usually or an ECMO daily charge, it's usually an inpatient charge. However, if you're transporting the patient, you could set up whatever charges you think are appropriate to cover the cost of care. So whether you get paid for that or not by the insurance company or by the other hospital who's maybe covering this transfer is up to your contracts and up to how that might work. You could, once again, if you're a hospital that transports the ECMO patient yourself and you feel you're incurring costs to care for that patient and cannulate them, then by all means, set your transport charges for ECMO appropriately. It's just whether you get paid for that or not is really determined by the contract and your relationship with them.
Okay. Right. That's all I have at the moment, and we'll hop back to you. Thank
Okay,
you.
I think there's like two slides left, so we can then open it up and people can
Okay.
questions as well. Um, so contribution margin, really important because if you work with us or you work with anybody in financing your hospitals, they'll usually talk about things in contribution margin or net operating income. And you want to, you'll hear often, we lose money on ECMO or we lose money on name the diagnosis or service. First thing you should ask is, what do you mean by that? Are you looking at contribution margin or are you looking at net operating income or you can just say net income because they're very different. If you look at contribution margin, almost ECMO will always be in the top of the range between reimbursement and your variable costs associated with it. If as long as you set charges correctly, it'll be top. If you look at net operating income, at most hospitals, everything loses money when you count all those other indirect costs that are very expensive at a hospital, right? The machinery, the equipment, there's staff everywhere. There's administrative staff, tons of management and admin folks. You all know that. All those are counted. Almost everything loses money. I mean, hospital margins on average are about 3%. And so I wouldn't take that as the end all be all around, hey, our program loses money. Yes, that has to be tracked, and you can't have every service line not make some type of profit. But in the reality of which services bring in the most amount of revenue, ECMO is usually up there. Once again, as long as you properly set it up. And it does vary by state and your payer mix. If you're in a state that has a very low Medicaid paying model, like mine, California, and you have a very high Medicaid population, it may not matter what you do. It's going to be very tough in those situations. Even if you set the best charges that are accurate and you adjust them, you may have a tough time making the numbers work in that model, and you might have to think about other ways that ECMO can help you, such as the halo effect, where, okay, we may not make a lot of money or any money on particular ECMO cases, but having ECMO in the hospital allows us to care for higher acuity patients by either transferring them in, by not transferring them out, by just the fact that we have ECMO available. And that halo effect is very important because it helps, surgical programs go, cardiothoracic programs grow, neonatology programs, which are some of the highest reimbursed services in the country, grow. So that halo effect is really important. Tougher to nail down, right? The CFOs and others want to see hard green dollars, like tell me exactly about how much ECMO is making. And so when you then talk about the halo effect of ECMO, it's not as easy to put a number to that. You know it exists. They can articulate that it exists, and it should be counted in some type of way to support your program. And then, as mentioned, that's where the net operating income, if they say you're losing a lot of money, you really need to talk about that. So I like this slide to kind of give you a high level overview of all the things you should be thinking about as you either develop a new program or are assessing your current program. We talked about payer mix quite a bit, out of your hands to a certain extent. I've been on two change the payer mix committees at my hospital over the last 28 years, both very unsuccessful. We're located where we're located within LA, and we get the patients we get. Okay. What are the reimbursement models for payers? In your control, can contracting go in and change payment models? If your state Medicaid program is in a payment model, I know there's about 6 states that still pay per diem. Out of your control. It's a very poor paying Medicaid model. ECMO contract carve-outs important. So I would talk to your contracting team and ask, do we have any contract carve-outs for ECMO? Meaning, yeah, we might have a contract that pays us APR or MSDRGs, but we want the ECMO DRG to pay us 200% of MSDRG, higher paying. Or say you have a per diem rate of $10,000, ECMO should pay you $20,000. Really try to carve that out. If you have a percent of charge payer, you don't have to do contract carve out for them. You can just charge more appropriately and you'll get paid more. So it's likely your hospital does not have contract carve outs, and that's something you should pursue. And we see a mix of success around that. Depends on what other ECMO sites are there around you in terms of competition, right? Do they have to this payer have to transport this patient out of state? They may be willing more to pay for your ECMO if they don't have to do that. We talked quite a bit around ECMO daily charges in your charge master. Figure out what your yearly costs are for your number of runs you have and the number of ECMO days. Adjust by your cost to charge ratio. And then many hospitals also even adjust for your fixed costs and add even more to that. My hospital does that as well to make sure that's correct. Make sure your docs are professionally billing properly and accurately for ECMO in the mid-cycle. So you set proper ECMO daily charges. Are the patients who receive ECMO actually getting properly charged for ECMO, or is the bill have the proper daily ECMO charges? So what we often say is there needs to be a reconciliation process before the bill goes out. The ECMO team and the ECMO coordinator likely know or should know this patient started ECMO today, got 6 days of ECMO, and then we took the cannula out. Does the bill match that and make sure it's accurate and has those 6 days? And if you have a higher charge for first day of ECMO because you're bundling in cannulation charges with that, is it properly set? If you adjusted the cannula or repositioned the cannula day 3, there's a charge for that too. Was that there? So it's really reconciling that. Usually with ECMO coordinator is a good way of making sure it's correct before it goes out. Make sure all your other ECMO related charges are accounted for properly, circuit oxygenator and such. On the back end, we talked quite a bit about discharge versus transfer status. Similarly, you should make sure that if you really put a discharge disposition of a rehab facility, somebody might have to call that patient and make sure they actually stay to midnight. It's going to impact reimbursement quite a bit. And then we talked about being in the correct DRG. So don't ask HIM or medical records, give me a list of all DRG 003. Start from the ECMO side. Say, here are the 25 patients and their account or FIN numbers. We know they got ECMO. Give us all the DRGs for them. And all of them should be in DRG 003 unless they had a transplant or unless they had a certain Impala, then they won't. But if you see somebody in totally different DRG, then it was likely miscoded as intraoperative heart-lung bypass, and you probably got under reimbursed for that. So it's a good way of just making sure things are coded properly. And then don't let these fall into the normal rev cycle queue of you bill, there's a denial or there's a delay or they recommend or they request additional documentation. So it falls into the normal queue, which can be sometimes too slow in rev cycle shops at hospitals. These are high reimbursed services. You want them pulled out, either specialized to one person who knows what they're doing, or at least the ECMO coordinator keeping a track of it to make sure that these go through the right flow and quickly get reimbursed, quickly deal with any denials or additional documentation requests. I am not Nicole, clearly, but if you are interested in hearing more about integration health services in many of the services I talked about earlier or program development, please scan the QR code there and reach out to Nicole, and she'd be happy to set up a call and help.
Yeah. I have a couple questions and maybe some more that come in, but one is to clarify if a patient is admitted to your ICU with septic shock or respiratory failure,
Yep.
then goes on ECMO, say after 5 days on ECMO and transferred out shortly after cannulation, do you collect a portion of the DRG based on the entire length of stay or just time on ECMO?
Your DRG payment is not impacted by length of stay. So here are the variables up top that go into creating what the DRG is with ultimately payment. What you don't see on there is length of stay. What you don't see on there is medications given, procedures done. Well, like studies done. There's a procedure done in the OR, as you can see. So in that example, they're admitted with sepsis. They get placed on ECMO. So it'll automatically fall into DRG 003 when that happens, if you're an MSDRG patient. And then if they get transferred out before 22.9 days to another facility, acute facility, then that packed policy will come into play and you'll get paid a portion of what you would have gotten paid by that DRG, which we described earlier. You just divide 200,000, whatever your DRG payment is, by 23 days, and then multiply that amount times the days they stayed at your hospital.
Okay. The next question is, can you get reimbursed for ECMO daily management charges if an APP enters the charges? These APPs manage the patients in ICU and complete daily notes.
Yeah, I assume you're talking about professional billing there and the daily management charges, which is here in the middle and the top. And the answer is it depends on your state and your medical staff rules. In my state, California, APPs, NPs in particular, because PAs and NPs are treated differently, are not independent practice yet in the sense of being able to do that in the hospital, though that varies quite a bit by your state and by your medical staff in the rules they have created around who can professionally bill or not.
All right. Is the higher DRG for durable LVAD like HeartMate 3 or Impella are percutaneous VADs and not for long-term use?
Read that question again, Neil.
Is the higher DRG for durable LVAD?
Okay.
Then it says like HeartMate 3, Impella are percutaneous VADs and not for long-term use.
Yeah, I don't, is it not for long-term use? I don't know the answer to that. I don't know those other devices go move you into 002 DRG, which is higher paying, 002, um, or 001. So
Okay.
I don't know the answer to that question.
Okay. When your ECMO patient is transitioned to 5.5 Impella as part of the recovery phase, how does that affect the DRG?
If 5.5 Impella is the one that is biventricular, and once again, I'm not a cardiothoracic surgeon, but not all Impellas make you fall into 002 here. But say they're on ECMO and then get on Impella, I believe actually 5.5 is the one that moves you up, then you would move up to a higher paying DRG in this example, which is good.
Sorry, let's see. Follow up regarding APP reimbursements. Who do I ask to get this answer? Would you know who they should ask? Their hospital's
Yeah,
professional
I would
reimbursement?
ask whoever does their professional billing. They either hire a company or their internal somebody department. They have professionally billing department somewhere. Ask them if they're unsure. You can ask your medical staff that credentials physicians and APPs. That's for my hospital anyway. Those are the two departments that would know that. But the first group I would ask is whoever manages your professional billing. And then compliance would be an important element of that as well, your compliance team.
In this question says, in your opinion, what operational infrastructure differentiates financially sustainable ECMO programs from those that are not yet optimizing their financial stability?
Um, Number one, out of your control payer mix and the state you happen to be in and their reimbursement model. Okay. Number two, the ones that we see are financially more stable are the ones that understand how to properly set the daily ECMO charge. We talked about that quite a bit and adjust for your cost to charge ratio. You might get pushback from revenue cycle or other folks like, no way, $93,000, 60,000, 100,000. That's not uncommon. Our room and board, our ECMO daily charge is $90,000 a day. And in California, charge masters have to be made public on certain health sites. So it's not anything, information I'm giving that's secret. And so that's really important. ECMO contract carve outs, also important because you could really squeeze out some more dollars for these high cost cases. And you should try to do that. So the challenge is there is no one magic bullet. you have to do lots of things right to have a successful program. You got to get contract carve outs if you can, set the proper daily ECMO charges, make sure that each daily charge is properly set for or accounted for on the bill for the patients that got them. Make sure they're coded properly and in the correct DRG, and that you quickly go after those dollars if they're denied on the back end. So you kind of have to do all elements of that correct. And so
Are I
one more
Go
thing to mention. Sometimes scale helps you, right? Obviously, as you do more cases, your cost is going to go up because you're paying for additional direct costs for those ECMO care. But there's lots of fixed costs in ECMO. The coordinator, you bought the equipment already. So the more cases you do, so you go from 20 to 40 runs a year. That can oftentimes lead to a successful program as well because you're sharing a lot of those fixed costs among a much higher number of cases, and you start to get that scale and efficiency that gets you to become more profitable.
okay. Um, are ICU room bed charges adjusted for the ECMO patient as well as staff that is managing the patient? And is this how you calculate the daily charge?
Most hospitals, mine included, have a separate ICU room and board charge, and then the ECMO charge is on top of that. Some hospitals have an ECMO daily room and board charge, and it converts to that. Either one's fine as long as you properly set those charges. So your ICU daily room and board charge should be the same roughly. Remember, the room and board charge is your nursing and other elements of care that don't have their own line item in the charge master. So it doesn't include labs or studies or medications, disposables, things like that. They all have their own charges. It's all those other elements of how do you staff in that department or that patient that go to those ICU room and board charges. So it shouldn't change. If you have a separate daily ECMO charge that's properly set, that daily ICU room and board charge shouldn't change at all.
Okay.
Now,
Uh,
if you have nursing in ICU that's 2 to 1, but with every ECMO patient they're 1 to 1 bedside nursing, then your daily ECMO charge should account for that by being higher to account for 1-on-1 nursing, and that way you can still keep your ICU room and board charge the way it is.
okay. I got a couple things. These I think feel like these are kind of related, and I know you've touched on a little bit about how each hospital is going to be different, but is there a place to find national benchmarks for daily charges? It says sometimes the finance department is concerned about increasing requested carve-outs or daily charges from very low level unless they know what a standard range is. And then the other said, how can we see what others in our state or region charge for daily ECMO charges?
Some states, mine included, require hospitals to publish their charge master. Though I'll be honest with you, many hospitals make it hard, make it very confusing. The charge master just looks like a gigantic, it is. I mean, charge masters have tens of thousands of rows of charges. And the description of it sometimes is like abbreviations and you don't even know what they're talking about. And that's probably on purpose from a lot of hospitals. So the short answer is no, there is no easy way to find. In fact, many of these hospitals protect their charges as their corporate, important secrets and proprietary information. So you're not going to be able to get that easily. There are consulting companies, I'm not advocating for any of them, that may have a good line of sight to a certain number of them, and those are the ones that help you develop your charges. But similarly, I don't know how they get all the data. There's no way they get all the data. They may have friends or connections at different hospitals, but there's no national or state repository of charges unless you're in a state that requires publishing, though I haven't heard a lot of states that do that. But there's really no good way to really understand that.
Um, any experience with an ECMO standby charge? The example they gave, CCL Tatters.
I've had no experience with that or wouldn't be able to help. Like as in ECMO standby charge, as in you funded ECMO to be there, you pay for the team, but they don't actually go on ECMO. I assume maybe that's what they meant. Um, I don't think there's any way to charge for that kind of availability, though never used.
Okay. Let's see. I think this one it's kind of probably a culmination of what you've been going. I think the daily charge is a big piece of this, but in your opinion, what are the hidden financial costs of ECMO that financially stable centers have uncovered and are charging properly for?
Yeah, I think I talked about it earlier and maybe set some on this list here. Your folks need training and there's precepting, there's service contracts to your equipment, right? So I would sit down with your ECMO leaders and your finance folks and just be like, okay, what are all the costs associated with us having this program? And all of those have to be properly accounted for. And so I think that's what I oftentimes see. And the bedside RNs are one, the ECMO specialists and coordinators are others that need to be properly accounted for to create your daily charge. But these are the ones that are not like the cannula and oxygenator that have their own line items of charge master. These are the ones that should go into the daily ECMO charge.
Yeah, and then let's see, this one may be one where we say, hey, you need to contact Nicole. She can probably give you some more insights on this one. But it says, speaking of scale, how are large systems creating sustainable ECMO staffing models across multiple campuses? Do you have any insights there?
Yeah, it's Nicole could definitely answer. I could just tell you it's not easy. That's why services like ours are really important because it's not easy to find the right experienced folks who know how to do this, who live in your area, and to be able to scale it, right? Like you may have no ECMO patient for a month and then three ECMO patients, next month. How do you staff for a program that has that kind of variability or could, or, 10 ECMO cases next month? So, you know, I think the way hospitals have been doing it is utilizing services like integration health to be able to provide that kind of support and when needed. Otherwise, particularly for certain states where it's harder to get people to move to, I think it's really tough to do that in a way that it lets you grow as fast as you want to grow.
Mhm. All right. And then for those who have asked, it's been asked a couple of times, we definitely will work on making this recording available once we get the opportunity to review and download everything. And we'll send out an email if we can. Um, let's see. Uh, to the offsite ECMO question, if your staff is going to an outside facility to cannulate or initiate ECMO, then transferred to our facility, can we charge the initial and a daily management charge?
That's a good question. So this is an offsite facility that's not under your hospital license, I presume. If it is something within your health system under the same, then likely yes, though that's a question for finance around are things done at that hospital, can they be billed under our hospital license and tax ID? That's for them. If not, and it's treated as a totally separate hospital, then probably not.
Yeah, it says it's a hospital outside our hospital system.
Got it,
So,
got it. Yeah, so
yeah.
that you'll have to have a separate contract, I presume, around if you're providing that kind of service there. Obviously, those folks need to be credentialed at that hospital to go into your hospital or that hospital and cannulate. They can't just do that if they don't have credentialing. So you hopefully would have set up some reimbursement structure that if your folks go over there and do that, you get paid X.
Yeah. Yeah, it says it's our staff and equipment to cannulate the patient. And then, but yeah, I'm assuming there's some sort of relationship there
Yeah,
that
yeah.
they've
Or
arranged
or you
ahead of
may do it
time.
for free to get that patient, right? That's not
Yeah.
also that's a realistic model as well, where if there's other competition for ECMO patients in your community and you're providing a service, well, we'll come to you, we'll cannulate and bring them to us. I bet you that would be very popular in your community, and I could see how that financially could be successful, even if you get no reimbursement from that initial cannulation.
Well, I'm scrolling through. I believe I've got to the bottom of the questions. We have some people who are showing their appreciation, saying thank you and that you've done an awesome job in this presentation. Do you have any last words before we all hop off here?
No, I thank you all for kind of paying attention to this important topic, right? I think us as, and there are probably a number of clinicians and program coordinators and directors on the phone, we can't bury our head in the sand about the importance of this element of it because we've got to make a business case and we've got to support the program. And if we want to grow it, ultimately for me, this is about how do we provide this service and grow it in our communities because our patients need it. And every year, the number of diagnoses that are amenable to ECMO continues to grow. And so, understanding that, creating your program to financially support that is really important. And hopefully you find this valuable and use services like Integration Health to help you grow your program.
Well, thank you so much again, Dr. Balkian. Thank you for all of you that have joined us. We will reach out to you as soon as we can with the um, uh, hopefully the recording and some other information about this topic. So thanks again for joining us and reach out to us if you need any help.